morning, Doctor.
Hoping all of you are okay. Alhamdulillah, all of you are okay.
Yes,
Very
Alhamdulillah.
happy, ambitious. Okay, so let us start by Salah for the Prophet Muhammad sallallahu alaihi wasallam for this Friday. Let us do it. Thanks, Allahumma salli ala Muhammad. اللهم صل على سيدنا محمد وعلى آله وصحبه وسلم. Now we have two groups to present. Okay, so we'll give a chance for the first group for an hour. They can handle the timing. The one who is not using the microphone, please switch off so we'll not disturb them. Let's go.
Assalamualaikum warahmatullahi wabarakatuh. Are my slide visible to everyone?
Yes.
Yes, okay. Okay, Assalamualaikum warahmatullahi wabarakatuh. I will start today. Me, myself, which my group, Balkis Ali, Wan Umaira and Maria, we will give a long case presentation. And firstly, we will start with a role play about history, about how to take history. And then we will present the case, and then we will do a little bit discussion about our case, and then we will give a little bit of OSCE discussion about OSCE slides. Okay, now for the first part is the history taking. And for the history taking, I will invite Balkis to conduct.
Okay, Assalamualaikum. So I will start the role playing now. Okay, I am Balkis, a medical student in IAUM. So before that, how should I call both of you?
You can call me Puan.
You can call me Mr.
Okay, Mr. and Ms. Simon and Mrs. Maria. May I know what is your relationship with Star?
I am his mother.
I am his father.
Okay, I would like to ask you some questions if you don't mind. But before I proceed, would you mind if I'm taking some notes along of our conversation for my references later?
No,
Okay.
you can.
Okay. First, may I know why is Sar being admitted to the hospital?
My son was well at first, but about 3 days before admission, he had fever. And the fever is warm to touch, but we don't have the thermometer at home to record the temperature. My son seems so weak, He can't even go to do kindergarten. So for what I remember, my son also have a loose stool at the same day, and uh, that's that's why I sent my son to hospital.
Do the fever, Paula?
Yes, it keep on worsening.
What do you do after you have found that your son had a fever?
We sent him to the clinic kesihatan right after that, and then the doctor recorded his body temperature, and I think it's around 37.8 degrees Celsius.
Does the doctor in KK give your son any medication after that?
Yeah,
Yes,
medication like a liquid syrup, the red one. Doctor said it is for relieving his fever.
Okay. Just now you mentioned about the loose stool your son had on the same day. Do you perhaps notice the color of the stool? Is it watery or something?
yes, it was watery and greenish in color.
No bloodstain and mucus in the stool?
No, no at all.
Let's say I have a cup this big. So can you estimate the amount of his watery stool?
Uh, I'm not so sure, but I think it's more than 1 cup. It seemed like in a large amount.
How many times each day?
Uh, uh, it is 20 days, 20 times yesterday.
Does he urinate frequently?
About his urination, I'm not sure about that.
Do you notice any blood stain or bubble-like appearance in his urine?
For now, no.
Sar, I would like to ask you a question. When you urinate, is it painful?
No, I didn't feel any pain at all.
I would like to ask if Sar has vomited at that time.
Yes, about 2 times. And his vomited could reach us that was several away from him. His,
Again, okay. Thank you. Again, is there any blood stain, greenish or mucus when he vomited?
no, nothing. Only the food that he just ate earlier, just
What
like
about?
rice.
Okay, thank you. What about his appetite after that?
I think due to his condition, he doesn't want to eat or drink anything, and much less than usual lah.
Sar, do you feel any pain at your body or itchiness? Does your throat hurt?
No,
Does your throat hurt?
also no.
Okay.
No,
Do you feel difficult to breathe? Feeling suffocated
mm,
or painful?
no,
Okay. Does Sar ever awaken during his sleep at night because of difficulty in breathing? Does he breathe noisily?
No, no, doctor.
Okay. Sar, do you ever eat the food other than your mom cook for you?
Actually, yes, I have bought him some kuih.
Okay. Okay, thank you. So, I would like to ask about your housing area. Are there any medical cases like dengue in the area?
I think yes, because I have seen some fogging activity recently, last week I think, at my
Can I
house.
know can I know how far your house with the nearest health facilities?
Around 5 minutes walk, 4 minutes away I think.
Have you ever visited any relatives or anyone who have the same condition like your son right now?
No. We have never visited anyone recently.
Okay, before I proceed the history taking, I will pause first. I would like to do the systemic review. In systemic review, I will observe on how the patient's condition. First, I will ask for his and his parents' permission to examine him a little bit, and I will look at his eyes to look for any yellow discoloration for scleral jaundice. And I will look if he feels pain or try to avoid the light to indicate photophobia. And I will pull his eyelids down with the thumb to look for pallor of mucous membrane. I will also ask him to pull his tongue out to check for bluish appearance for sinuses, and I will check the any gum bleeding and bruises or swelling for bleeding tendency. Okay, so I'll proceed with the history taking. So, Mr. Arman and Mrs. Maria, if I may ask, is it his first time being admitted to the hospital?
Yes.
Does he have any allergy, any illness, or any undergone any surgery before?
No, nothing.
Now, I would like to ask Mrs. Maria about your pregnancy. So, during his birth, is it in the normal delivery or you have been assisted with vacuum method or surgery?
No, it was a normal delivery. He was born in the full term, but the doctor said he has jaundice and it's about 1 week.
Do the doctor perform any transfusion to him for jaundice?
No.
What about his diet? Does he get breastfeeding before?
Yes, he was being breastfed until 6 months old, and then I started to give him soft food. At 2 years old, he started to eat usual food, the adult's food.
So his diet is okay, the amount of food and type of food he has taken.
Yes, he usually takes 3 meals per day. That consists of a plate of rice with eggs or chicken. How, but he does not prefer vegetable or fruit.
How about his performance? Does he walk or talk like someone else? Or anything you find unusual in his speech or movements?
No, he looks okay to me, like how his friends in the kindergarten as well. His teachers also said that he's doing good in kindergarten and he can play well with everyone and even the strangers.
Does he take any medication before except the syrup?
No,
Okay. Does he have any allergy to medication?
no, no, no.
Does he take the vaccine correspond to his schedule?
Yes.
Is there any allergic reaction like rashes or fever after his vaccination?
No.
Is there any family member that have an illness or allergy?
No, no.
Sorry to ask, but do you, Mrs. Maria and Mr. Ayman, related to each other, like cousin?
Oh, no, no, no,
Okay.
no.
Uh, Again, I'm sorry if this question seems improper to you, but I need to ask this for the sake of having accurate interpretation for your son's condition. So, have you, both of you, have ever been smoking?
Yes, yes, a lot.
I'm not.
How long have you been smoking?
I smoke a lot, 2 packs every day for about 15 years.
Okay, thank you. Before we end, is there any concern about your son that you may want to share with me?
No, I just hope that he is well. That's all.
Inshallah, we will try our best to treat your son. Okay, I think that is all. Thank you, Mrs. Ayman, Mrs. Maria, and Sar for your time. Okay. After taking the history and made some physical examination that consists of vital signs, abdominal examination, respiratory, CVS, and neurological. This is the summary of my case. Sar, a 5-year-old Malay boy, was admitted to HTAA due to fever and loose stool for 3 days duration. The fever increased gradually and relieved by syrup PCM. The diarrhea was more than 10 times each day, and each time the stool was in large volume and watery, which is me classified as Bristol 7. No presence of mucus or blood in the stool. He vomited twice of food contents with no presence of bile, mucus, or blood. He had history of taking outside food and lived in a dengue-prone area with recent fogging noted. However, it is not associated with rashes, respiratory, musculoskeletal, and also urinary symptoms. Other systemic review were unremarkable. On physical examination, he has signs of dehydration, including sunken eyes, mild coated tongue, and dry lips, which indicates moderate dehydration. So that's after done few investigation, the final diagnosis is acute gastroenteritis with moderate dehydration. And then I'll pass to Aiman to discuss about our final diagnosis. Thank you.
And okay, thank you for discussion. Gastroenteritis is the inflammation of stomach and intestine, which increase stool frequency, which alteration in the stool consistency. So basically, acute gastroenteritis is highly associated with diarrhea. And for the etiology, it could be infected from bacteria, virus, or parasitic infection. Which different etiology will have different different mechanism and pathophysiology on how it will affect the diarrhea. And I will not go through all of it. This is just a summary. As you can see, for the example, it's for the lower row. It is the example of organism that may cause enteric infection. And as you can see here, there will be two types: watery diarrhea and dysentery, which is bloody diarrhea. And in our case, this boy have profuse watery diarrhea. So this the etiology might be one of these here. And for infection, parasitic infection may also cause acute gastroenteritis, such as Giardia labiasis or Entomypha histolytica. And that's why in history taking, we also need to ask whether this child have ever go to the watery places or any place that have water. And this is clinical feature of acute gastroenteritis. Basically, you will have diarrhea, nausea, vomiting, fever, abdominal cramp, and electrolyte imbalance syndrome is one of the complications of diarrhea. Uh, for the complication, which is dehydration. Dehydration is one of the complications of diarrhea, whereby dehydration can be divided into three, which is mild dehydration, moderate dehydration, and severe dehydration. To assess dehydration, we need to look at this symptom, which is mental status, the stirs, how the breathing, if the eyes sunken or not, look at the mouth and the tongue, look at the skin rigidity, and capillary refill to assess the our is to assess any cold extremities and etc. etc. And in our case, Sarah have moderate dehydration, and different type of dehydration have different set of management that we could do, and I will explain after this. For investigation of acute gastroenteritis, we can do full blood count to assess infection. Is there any increase of neutrophil or leukocytes to indicate infection? Usually, bacterial infection of acute gastroenteritis will increase leukocytes, whereby viral infection we will see we seldomly see increasing much in neutrophil or leukocyte. And renal profile to assess our kidney function because of the diarrhea and to assess the electrolyte imbalance. Venous blood gas is solely to assess electrolyte imbalance because of the diarrhea. And finally, stool culture and stool full exam microscopic examination. Stool culture is if we suspect it is a bacterial infection of acute gastroenteritis. We can do stool culture, whereby stool full exam microscopic examination we do if we suspect this is a parasitic infection. And this is the reason or little comment. And this is what I just summarized just now. And for the management, they will have plan A, we have plan B, and plan C. Basically, plan A, plan B, plan C is different according to what the severity of the diarrhea. So we do plan A if we suspect this diarrhea is only mild dehydration. So what is plan A? Plan A is we advise this mother to give extra fluid at home and continue feeding. If the baby is breastfeeding, we advise the mother to give more breastfeeding than usual, and we also tell them when to return to the hospital, which is if the diarrhea persists, the mother could return to hospital or clinic. And for plan B we treat moderate dehydration, whereby we give ORS to replenish the hydration status. This is the how we want to do the ORS, whereby uh, we to determine what is the dosage or volume that we need to give. We multiply the child weight if which 75. So let's say that SAR is 15 kilogram times 75 is equal to 15 75. Yeah, that's a. And then plan C is to treat severe dehydration quickly. And basically, firstly, we give attention to ABC and airway breathing and circulation if this involve breathing and respiratory syndrome. And then if when we have done with the ABC, we do intravenous and IO fluid immediately. And then and then we give initial fluid for resuscitation of shock, which is 0.30 milliliter of kilogram per kilogram of 0.9% normal saline. And after we give the resuscitation of shock, we commence hydration. So how to commence hydration? We give we just take percentage of the dehydration that we assess just now and times by the body weight in gram. Let's look for the example. So let's say that first step we treat ABC, right? And second step we treat for the shock if this boy have shock. So 20 milliliter per kilogram times by the body weight, which is 12 kilogram. First we give 120 milliliter of 0.9% NS in oceanic intravenous bolus. After we give this, we commence hydration by by times the hydration percentage, which is 10%, which you can see 10%, times by this child weight in gram, which is 12 kilogram equal to 12,000, 12,000, which is we give 1,200 milliliter. And we also know to give daily maintenance fluid. Daily maintenance fluid, the formula as below. This is for the management. Basically, for the management of acute gastroenteritis, we treat the diarrhea and also the fever. And that's all for me. Now I pass one Umaira to discuss about the facial diagnosis.
Yes, Assalamualaikum. Now we go to the differential diagnosis. And here we put 4 differential diagnoses, which are food poisoning, dengue fever, parenteral diarrhea, and also acute appendicitis. So we go one by one. First is food poisoning. Food poisoning is one of the differential diagnoses because food poisoning due to bacterial toxins frequently causes symptoms very similar to viral gastroenteritis. So the suggestive points of food poisoning from this child are fever, loose stool, vomiting, history of taking outside food, and also signs of dehydration. And in this child, the signs of dehydration are sunken eyes, mild coated tongue, and dry lips, which indicates moderate dehydration. And the point against food poisoning is there is none of the family members or friends at the kindergarten had the same signs and symptoms. And the second is dengue fever. The suggestive points are the child had fever with chills and rigor, loose stool, vomiting, signs of dehydration, and live in dengue prone area. But but the point against dengue fever are no rash, no muscle or joint pain, and no retroorbital pain. And as for the third differential diagnosis is parenteral diarrhea. Parenteral diarrhea is diarrhea due to infections outside the gastrointestinal tract. And infections elsewhere in the body such as otitis media or more frequently urinary tract infections are sometimes associated with diarrhea. So the suggestive points for parenteral diarrhea are fever, loose stool, vomiting, and signs of dehydration. But the point against parenteral diarrhea are no symptoms of urinary tract infection, no urine or discharge, like in the otitis media, and no cough, sore throat, or runny nose. And another point against parenteral diarrhea is the child pass about 10 times stool per day and about 20 times for today. So typically in parenteral diarrhea, the patient will pass only 2 to 3 loose stools per day rather than 5 to 10 loose stools seen with most acute gastroenteritis. And lastly is acute appendicitis. This is differential diagnosis as it is also the most common surgical condition of abdomen in children over the age of 4 years, and it always it can cause morbidity and mortality in Malaysia. And for acute appendicitis, the suggestive points in this patient are fever, loose stool, loose stool is more common in the appendicitis of younger age group, and it always causes the confusion with gastroenteritis. And also the child had vomiting. For vomiting, it occurs as an early symptom in about 90% of children with acute appendicitis. And also the child had poor oral intake. While the point against acute appendicitis is no abdominal tenderness, as tenderness on palpation or percussion is essential for the diagnosis of appendicitis. So I think that's all from me, and I'll pass to Maria for the
Just a while.
OSCE slide.
Just a while. Come back, please. Come back to the same slide. Uh, for food poisoning, you need to add one table about just a clue for food poisoning, what may be the organism, because food poisoning will be differentiated according to the timing of symptoms. It appears just within 2 hours, within 6 hours, within 48 hours. So you must to know something because we are a country we used to eat outside. So it must be very clear to us. This is number one. I know that the age of the baby, but instead of putting acute appendicitis, you just put surgical cases. Okay. Another common surgical case, but we will see it in small infant, which is intussusception, of course. Okay. But you didn't put the differential diagnosis here, dysentery also. So why you missed the both? So you need to add a dysentery, which is very important if it is blood, mucus, and you need to add some surgical cases. You need to add some details about the food poisoning. And I think the first presentation you need also as a group to add the mechanism of diarrhea. Is it secretory or not? You can differentiation. For this, we need to add also a differential diagnosis of chronic diarrhea. What is the definition of chronic diarrhea?
episode of diarrhea that begins acutely and lasts for 14 days or more.
Okay, so we must keep in mind the differential diagnosis of chronic diarrhea, or even we can accept the definition of prolonged diarrhea. Okay, so all these need to be added. So one of the most common cause of infant childhood death is the gastroenteritis. Sometimes you are not understand that, but this is a reality. The other issue, what is the, maybe for Balkis now, what is the sequence of dehydration? Everyone mute his phone, please. Only Balkis now. What is the sequence of dehydration if you didn't manage the dehydration?
Uh,
Shock.
the, the, doctor, do you mean symptoms or treat
No,
management?
the sequence. Sequence. Yeah, no. If you didn't management the dehydration, what is the complication or the sequence which you suspect?
Shock.
Um, or sh- shock, shock,
Okay,
hypovolemic
how
shock.
many types? Okay, what else?
Oh, how many type of shock?
No, we said hypovolemic shock. Hypovolemic shock can be two levels,
Uh,
which is, what is how can you differentiate between compensated or decompensated?
when if it is compensated is when it can resolve when we give infusion of chloride solution. No.
So you are diagnosing it by the prognosis.
I'm
No,
sorry.
we need to diagnose it early. So who can answer?
Okay.
If
Able to maintain the blood pressure. The
Yeah,
body able to maintain the blood pressure.
this is the most important point. Compensated shock, still you will find the baby has the signs of shock. Decrease capillary, increase capillary refill time, decrease perfusion, baby is lethargic, like. But still he can compensate his blood pressure even with mild tachypnea. If you didn't pick the child at that moment, we can go for the decompensated. Sometimes you call it reversible shock and irreversible. It means sometimes you are not able to save the child because it is irreversible time. That's why we must concentrate the sign of dehydration. We are year 5. It is just a few months. We must be able to take decision rapidly to save the life. Okay. We will discuss after that about clinical diagnosing the signs of dehydration. The other one, other complication of dehydration, we said shock, another,
Renal failure.
yes, can affect the renal impairment. Also, you must know that kidney is the organ which excrete the fluids, okay, glomerular filtration rate to give urine. So it is very important while getting the history to ask what about the urine output, okay? Because if the mother told you my baby doesn't pass urine for 12 hours for or longer time, you must be very cautious. Because kidney, what is the type of renal failure here or renal decompensation? Case of hypovolemic shock. Still, we are asking Balkis. Balkis?
Yes, doctor.
What is the type of renal impairment in hypovolemic shock?
I don't know.
So how many types of renal failure do you know? Pre-renal, renal, and post-renal. Yes.
Post-renal. Okay.
Pre-renal, renal, post-renal. What did you suspect in severe dehydration will be the cause of the renal failure or renal impairment? Mhm. Yes, Atira.
Due to hypovolemia, cause the
Yes,
pre-renal.
pre-renal. So it means the pre-renal, there is less fluid coming into the kidney, so started to be impaired. If we didn't take care and treat it very rapidly, it will turn to be renal. Okay, that's why must take care, please. About. Okay, another complication of dehydration, Balkis. You said can be renal impairment, it can be shock. Any more?
Seizure.
Secondary to
Electrolyte loss.
very so
Impairment.
it is electrolyte
Imbalance.
discharge. What is the most important electrolyte you must get a look for it?
Hypokalemia.
Yes, potassium is very important. Okay, but
So
also one more. We know that hypokalemia can cause like alias. Okay, I agree, but the most important is, as you said, sodium. Why? Because we are dividing
ISO.
the
Okay.
gastroenteritis into 3 types, which is
Isonatremic, hypo, and hypernatremic.
yeah, this is the most important. So if you suspect, that's why you are doing the sodium. It may be sometimes of hypernatremia. We need to give the fluid, but we need to restrict the sodium according to the regulation. Okay, so that is the issue.
Okay.
We are trying now to deal as a clinician, okay, not as a student, try to get a global impression about the situation and how it can affect, because even if you neglect the dehydration, sometimes the baby can get derangement of the liver and he got like DIC, disseminated intravascular coagulation, and it happens. If some baby came from remote area and he is dehydrated for a long time and no fluid, he'll come to you vomiting blood. If you did the coagulation profile, you will find it attained. So the baby now looks in very late situation. Okay? So our responsibility here in front of our professionality, in front of Allah, who will make us responsible for the other to care them, it must be we are very professional, please. Okay, very careful. Try to get the history, very important. Put every differential diagnosis. That's why your colleague asked for blood gas. Who is presenting the blood gas? Akmal or whom? Okay, no issue. Akmal, can you tell me what did you suspect to see in the blood gas of gastroenteritis?
I can hear you, doctor.
What abnormalities we can see in the blood gas?
Abnormality that we can see in the blood gas.
Yeah. forgot about your slide. Don't go to the slide. Go to your mind now.
No, I'm not.
Now, yes, we need to transfer the knowledge from book to brain.
I
This
believe
is our goal at the time. Yes. What did you believe?
I believe that the oxygen level in the blood will reduce since there will be hypoperfusion because of the fluid loss, isn't it? And there might be acidosis also. And when there is acidosis, I suspect that there might be also increase in carbon dioxide in the blood. That is my.
What type of acidosis? What is the type of acidosis?
I think metabolic acidosis.
Yeah. So metabolic acidosis is an
Yes.
important clue for also for the severity. Okay. It's the same which happened. Which one of the differential diagnosis you didn't spoke about, which is DKA? What is the DKA? I will choose Nurul Sufiana. What is the DKA?
Diabetic ketoacidosis.
So it can be presented looks like gastroenteritis also or not?
Yes.
Yes, because the child sometimes presented by abdominal pain and started to vomiting. Okay, so he looks like very dehydrated. Okay, that is the most important. We are diagnosing the severity of the DKA by the blood gas and the ketone. Its name is diabetic keto. It means there is ketone and the acidosis. The same will happen if the patient got severe dehydration. Will find the metabolic acidosis. Okay, so blood gas in any critical situation, you mustn't forget it. And as I used to said, this is the hand of the patient. Don't forget for pulse oximeter. Don't forget for the blood gas. The same, the base of the thumb. And the patient in severe asthma or like that, you can use also the big expiratory flow rate. Okay, which is on your hand. Okay, don't forget it, please. Okay. Okay, you can continue your presentation, please?
So I will talk about the first key question. For the first question, it is given two pictures. So what is the sign that you can see in these patients? What is the condition? For B, give three other signs of the condition and state one possible diagnosis. So in this patient, for the answers, we see the sunken eyes. For A, it is deeply sunken eyes. For B, it is just sunken eyes.
Ask them and ask them to answer, please.
Oh.
Don't ask them and then you answer.
Oh,
We need to
sorry.
share. We cannot do even online and every one person are speaking. That's why I didn't prefer to speak a lot with you. You can assign anyone to answer, please.
Okay. So I have stated what is the sign. Umairah, what is the condition for picture B?
Sunken eyes.
There is the sign. What is the condition?
Dehydrated.
Yes, dehydration. For B, it is just sunken eyes, so we classify it as moderate dehydration. what about A? Balkis for deeply sunken ice. Balkis.
Uh, so severe severe dehydration.
Yes. Yes. For A, it is severe dehydration because deeply sunken ice. For B, is moderate dehydration. So for question 3, give 3 other signs of the condition that is stated in Q2. Means condition B is moderate dehydration, right? So what is the other signs for moderate dehydration? Aiman?
May I answer? Reduce urine output.
Reduce urine output, yes. Another one? Another two?
Uh, uh, is loss of appetite another one?
Loss of appetite. Okay, next answer. Mm,
What about reduce skin turgor? Turgor. Turgor.
Rigidity, yes.
Okay. Rigidity.
True. True. So there are three signs. So there are many other signs of moderate dehydration. I'll explain after this. For question 4, give one possible diagnosis. Atira, what do you think is the diagnosis?
Acute gastroenteritis.
Yes. Okay. I'm on next slide, please. Okay, so for the answers, number one is sunken ice, as I said, and from picture B is moderate dehydration. Another, if you want to assess the severity of the dehydration, according to pediatric protocols, these are the signs. Look at the child's general condition. It is well alert, restless, or irritable, lethargic, or unconscious. And also look for the sunken eyes. Um, for in pediatric, it shows that moderate and severe both have sunken eyes, but in another book it said that severe have deeply sunken eyes. And then look, offer the child fluid. For moderate dehydration, he will drink eagerly or he will drink thirstily. For severe, not able to drink. And then if we pinch the skin of abdomen, which is to measure the skin turgidity, the skin for moderate, it goes back slowly but takes about 1 to 2 seconds. For severe, it takes more than 2 seconds. Okay. Next. Okay, for question 2. A 5-year-old child came with acute gastroenteritis, just like our case, the case that we have presented. So what is the most common etiology of the disease? Give one example. Supriana?
E. coli bacteria. E. coli.
Yes. Okay, true. E. coli is one of the etiology. which is a bacterial infection. The example is E. coli. So what is the most serious complication of the disease? Which this is one is Dr. has stated before. Suhaib,
Is it dehydration?
yes, dehydration. Dehydration or more accurate is dehydration that leads to shock, hypothermic shock. Next question, give 3 signs that helps to identify children at risk to develop the complication. The complication is dehydration that leads to shock. So what are the 3 signs that can help to identify that the child is at risk to develop the complication? Akmal,
Sunken eye.
okay.
Sunken eye. After that, can the capillary filling time is reduced? Capillary filling time increase. Can it be
Yes,
the one sign?
reduce. It
Yes,
is
and increase.
capillary filling time increase. Okay. Next.
Another one.
Other person? Anyone?
No, for this one, for the answer of this one, please don't forget, I know that all of you are concentrating on ABC and it is a must, but don't forget that the vital signs are
Oh,
vital. Its name is vital sign. Vital signs are vital. You comment about capillary fill time, must comment about the pulse rate. Can you please turn off your microphone, the one who is not using? The most important is the vital sign. Please remember that vital sign is not vital. Even in the exam, if you didn't mention about the vital sign, you are in danger. Pulse rate, it will start to increase as a sign of shock. Blood pressure, if started to decrease, but we have 2 stages, differentiation between compensated or decompensated shock. Anyone knows what will happen with the blood pressure?
Is it supposed to be increasing due to compensated hypovolemia?
The body cannot overcorrect.
can I suggest?
Cannot increase. But the first, the systolic blood pressure will remain, but the diastolic will increase. Okay? Then after that, both of them will decrease if it is irreversible. So please, blood pressure is very, very, very important. Pulse rate, even respiratory rate. Because do you know how can clinically, how can we diagnose the severe metabolic acidosis? What is the type of respiration? Type of respiration on metabolic and significant metabolic acidosis.
Is it too small respiration?
Yes. What is small?
Increase rapid breathing.
So why is it said cosmol? Cosmol has its own description.
As a compensation for metabolic acidosis?
No, it is a deep and rapid. Deep breathing and rapid. If you saw it once, you will not forget.
To expel more carbon dioxide.
Yes, I mean the description of cosmol breathing, it is deep and rapid. It is not only rapid, but it is deep. The chests are deeply working. If you saw him once, you will not forget DKA. You can diagnose it clinically if you find this type of breathing, even if neonate, if severe. So it is very important the type of breathing. If it is cosmol, please come and revise the type of breathing to end the session between the cosmol, between tachypnea. It is very, very important because this is ABC in medical practice. Okay. So don't forget the vital signs, which can give you a clue that the baby is severely dehydrated and going for shock or not. With other point to speak about. Okay, continue your slides.
Back, last question. Back.
Okay. So
Okay.
did you finish all your OSCE now?
The last question. One last question.
Okay.
So the child is identified to have mild dehydration. So what is your treatment plan? And explain about it briefly. Can I ask Umaira? For mild dehydration, what is the treatment plan?
We can give extra fluids
Okay.
and give continue feeding, give enough food.
Okay. Continue feeding. Give more fluid. And and advise patient when to return. So for the treatment, next slide, Aiman. Okay, sorry for question one, please. Okay, for question one, the most common cause in developing countries like Malaysia is bacterial infection. One of it is E. coli. For developed countries like Europe, US, the most common is viral infection, which is caused by rotavirus. And the most serious complication is dehydration that leads to shock. And those are the signs of risk factor that can develop to shock. Next. Next. Okay, this is from back. Table. I mean, go one slide back. Okay, this is from NICE guidelines. So pay attention to the red flag in the middle column. The red flag is the signs for the children that can have that may develop to shock, which is appears to be unwell or deteriorating, altered responsiveness, such as irritable and lethargic, sunken eyes, tachycardia, tachypnea, and reduced skin rigidity. Next. So for mild dehydration, the plan is plan A, which is just to treat diarrhea at home. And these are the three important points. Give extra fluids, continue feeding, and when to return. Next. So for give extra fluids, just tell the mother if for this case, the child is 5 years old. So usually it is not exclusively breastfed. So just give one or more of the following, which are ORS, food-based fluids, or cool boiled water. And then show the mother how much to use ORS to give in the usual fluid intake. For more than 2 years, it is 100 to 200 milliliter after each loose stool. But if the weight is available, give 10 ml per kilogram of ORS. And also tell the mother to give frequent small sips from a cup or spoon. And if the child vomits, wait for 10 minutes and then continue to give the extra fluids and give it until the diarrhea stops. For continued feeding, for children that already can eat solid foods or semi-solid foods, continue to receive their usual food. And when to return, the patient is advised to return if the child is not able to drink, becomes sick, develops fever, and also has blood in stool. Okay, I think that's all for OSCE presentation.
So, question for you. If the patient has mild dehydration, you are going to send all them to home?
For mild dehydration,
Yes.
we give we first treat with ORS and then assess after 4 hours if the child is still mild dehydration. I I think the child can discharge. Like do plan in educate the mother.
Okay, there is an important point considering the social situation. I mean, if this child is orang asli and you are afraid if you discharge him, the family cannot understand if it progress. You are not giving, because you are not only giving ORS, you are giving them extra instructions. If the vomiting is persistent, if the diarrhea is severe, if the baby started to refuse feeding, like all this is clear, okay, instructions, okay, which looks like instruction plan for this child. He must know it. If you feel that the family cannot understand or you are afraid of the baby, sometimes I am not speak for this specifically, but social situation must be considered. Because yes, in the book it is documented like that, but in other area you will find something like social admission. If the patient like from very remote area, he has no nearest follow up, you see that the baby, the family cannot take care about the knowledge about take care about the baby, so must be considered. Okay. Did you finish your first case?
Yes.
So before I finish, I need one of you just quickly tell me if the patient in front of him, how he check for dehydration. I will check the last one or two, one Omni or Omni F. One of you can answer quickly within short time. Omni F.
Doctor, can you repeat the question?
Examine the child for dehydration. Tell us what you will do rapidly.
To inspect the patient
Yes.
for sunken eyes.
What else? Is it sunken eyes only?
No. For the capillary refill time.
No. I am speaking about the eyes. I'm speaking about the eyes. Other clinical sign in the eye?
Jaundice.
Yes, but I'm speaking now for dehydration, not for the cause of diarrhea. Who can tell us regarding the eyes? It's very important and to guide you.
Oh, if the patient cries but no tears come up.
No tear, it is the same as if he is not passing urine, no extra fluid in the body. Okay, so for the eyes, it is very important to consider the sunken eyes and no tears. Okay. Is it the eye is number one, or you can go slightly up before coming to the eye? For the skull, is there any clue for dehydration?
If the skull is, I'm not sure what's the term, but when there is, if it's severe dehydration, I'm not sure. I'm not sure.
Who can answer? Very important. Forget about the age, especially if it is infant.
Is it the temple? You know, you can see the temple of the patient.
Anterior fontanelle.
Oh,
Oh,
So you must start systematize. We'll start up here. If the anterior fontanelle is still opened, you must start by it. Is it, what did you suspect it to be? Ifa? Ifa? What?
To be sunken.
Sunken. But if you found it protruded or bulging or tense,
Maybe edema, cerebral edema.
so which diagnosis are considered now? Bulging anterior fontanelle or tense one? I suspect meningitis. Don't forget that meningitis will be presented by vomiting, and it may be the baby also get slightly loose stool because of the infection itself. So they may come to us and deceiving you. My baby has the resistant to vomiting, and if you didn't ask about what are the type of vomiting, is it projectile or not, you may be also accept the family diagnosis, which is wrong, that it is EGE. So please, I just asking you because I need you to be systematized. So try to put a system for yourself. It is from head to toe. Okay. So we'll start from the anterior fontanelle to check how depressed is it. And if it is increased, I may suspect many things. I don't want to fool your mind by a knowledge which may be premature for you, but even sometimes abnormal coagulation can close and looks like bulged anterior fontanelle, or if we have suspected meningitis or intracranial pressure. Number two will come for the eye. We will not accept only the sunken, but without the sunken, if no tears or not. Then if I will go to the mouth, continue. Continue signs of dehydration.
Dry mouth.
What else can be also? Can be coated one. Okay. Can be featured if this is chronic diarrhea and the patient has like vitamin deficiency. So what about for one amni? What did you suspect to find in the neck? The jugular venous pulse is important or not? Especially if the patient is eldest enough, it will guide you. Okay. So Akmal.
Hello?
Yes.
Okay. Sorry, doctor.
Okay. So can you continue? We see the neck. We are making sure about the jugular venous pulse. What else do you need to check for dehydration?
How about the skin?
Okay. What did you suspect to
Become
find it?
pale. or mottled?
Okay, mottled in small child, yes, can be. Okay. And of course, the skin turgor is a gold standard. Do you know how to do skin turgor?
We pinch the skin. Is
Okay.
it?
Then after we pinch until the
And
child
then
cry, or
and then
pinch.
we look for the and then we look for the skin to rebound. Is it rebound you say?
Yes. So
Return
is
to its normal shape.
a longer time or not? But did you suspect
Ah,
that there is
yeah.
some cases skin turgor baby may have dehydration and the skin turgor is not helpful? Mhm.
Not what, doctor?
Skin turgor sometimes looks not prolonged in spite the patient has dehydration.
Oh, all people, sorry. Because all people they usually already have that kind of skin already this dehydration.
Yes, it can be abnormality in the skin, but if the skin is normal, sometimes hypernatremic dehydration can cause dewy skin. It is not skin turgor, it is dewy. All the skin are affected, and even the tongue will be like woody tongue. It is different dehydration. That's why I need you to build up your knowledge session by session, case by case. So when you see the patient, you are able to put your initial clinical judgment. Okay. Okay. After the
Okay.
skin, what other important area we need to examine to define the severity of the dehydration? Is it the hand is important,
Yes.
or what is this? If I did like that, what is this test known as? Capillary refill time, the pulse, the blood pressure. Okay, it is very important to check about urine output. You must know how to calculate the urine output. What is the normal? How many ml per kilo per hour? Okay, and if it is decreased like that, it is very dangerous. And don't forget, please, to weigh the baby, because you are most of the classification depend on loss of weight. Yes, so you must weigh the baby and see how much, and if he has previous record, how much he lost, it will guide you also. Okay, that's why we are trying to just imitate our clinical scenario. If I see the baby with dehydration, I must start from up down. I must concentrate about signs of dehydration, the fontanelle in the eye, in the mouth, in the neck. I will check the capillary refill time and the vital signs. I will check the skin for any abnormality of dehydration or mottling or like that, or decreased perfusion. I will check about the urinary output. I will check the weight of the baby. All this are very, very, very important to go systematize and try to finish it in a few seconds so you can take decision after that. How severe is it and what I should do? Okay, let us go for the second case, please. Hoping we can finish at 12 and a few minutes, so we can go for Gumaat, inshallah. Okay.
Can you guys see my screen?
Yes.
Assalamualaikum warahmatullahi wabarakatuh. Me, Nur Sufena, and my friends Atira, Suhaib, and Akmal. We are from subgroup 2, and we are going to present a case on respiratory system. So firstly, we are going to do a role play on history taking that will be conducted by me and Atira. Then proceed with summary. Then Suhaib will be presenting about differential diagnosis. Atira will be presenting about investigation and management. Then lastly, Akmal will be presenting about objective structured clinical examination or C. Okay, so now let's start with the role play. And I'm going to be the medical officer in charge, and Atira will be the mother of the sick child. So okay, let's start. Um, Assalamualaikum, ma'am. I'm Nur Supriana, medical officer in charge in pediatric clinic today. How can I help you?
Waalaikumsalam, doctor. My son has runny nose and it already persistent for 4 days.
So how old is your son?
He is 5 years old.
What is the color of his discharge coming out from his nose? Is it clear or yellow or green?
The discharge is clear.
Okay, does he go to school? If
Uh,
yes, did you notice that any of his friends having the same symptoms?
Yes, he did go to school and there were many of his friends that has flu-like symptoms.
Uh, does he have any other symptoms like coughing or fever or sore throat?
He does not have fever and sore throat, but he had cough since 2 days ago.
Okay, what does the cough sound like? Is there any abnormal sound about his cough?
No, it was just normal sound.
Is it dry cough or wet cough? As in he bring up any phlegm? Or if there is phlegm, what does it look like?
Yes, his cough comes with phlegm that was whitish green in color.
So, how much his phlegm was produced? You can, is it 1 tablespoon or more or less?
I think it was less than a tablespoon, around half of tablespoon.
Okay. Does he complain any chest pain with his breathing?
No,
Is there any swelling around his body?
no, there is no swelling.
Was he exposed to any allergens before having the symptom, like exposed to smoke or dust or pollen?
As far as I know, he did not expose to any smoke, dust, or pollen.
Okay. Is there anything abnormal about his breathing?
Yes, I noticed he had rapid breathing since 1 day ago.
Can you describe his breathing? Is there any abnormal sound?
Yes, there were like a high-pitched whistling sound, and his chest was sharply pulled inwards every time he breathed. Then I brought him to the clinic kesihatan, and his breathing has improved since.
Did he complain any pain when he breathed, or does it affect his physical activities?
No, he wasn't complaining any pain and still can walk.
Okay, thank you. What about his food intake? How many meals he took a day?
He used to eat 3 meals a day, but now only 1 meal a day.
Okay. Okay, now ma'am, I'm going to ask you about his birth history. Have you ever received blood transfusion when you were pregnant?
No, I had low hemoglobin but never received transfusion.
Have you ever lost consciousness because of your low hemoglobin?
No,
Did you smoke when you were pregnant?
no.
What about your labor? Was it a normal delivery?
Yes, it was normal delivery.
Do you still remember his birth weight?
His birth weight is 2.67 kilograms.
Are there any complications that occur?
No, but he had jaundice for a few days after delivery.
Did he get treatment for the jaundice and
Uh,
was he admitted for that?
he did not get admitted or require treatment.
So may I know, did you breastfeed him? If yes, for how long?
Yes, up till he was 6 months. Then I mixed with formula milk until he was 2 years and 4 months.
When did he start his complementary feeding?
It started when he was 6 months.
Okay. Is he now a picky eater? Does he eat his veggie?
No, he is not a picky eater and he enjoy his veggie.
Does he have any food allergy?
No, he did not.
Does he receive his vaccine and complete them?
Yes, he did not miss any and has completed his vaccination.
Okay, thank you. So now may I know about his performance at school? Does he play well with his friend?
Yes, he often plays sports with his friend and he enjoys skipping.
What about his writing and drawing skill? Can he draw shapes?
Yes, I've seen him draw square and triangle.
Okay, good. Can he dress by himself?
Yes, he doesn't require my help.
Okay, what about his medical history? Has he ever get admitted before?
Yes, he was admitted 6 months ago due to bronchial asthma because of his breathing. But before that, he only come to klinik kesihatan few times for nebulization.
What medication was he prescribed with?
As far as I remember, it was fluticasone and salbutamol. And I made sure he inhaled fluticasone daily and salbutamol when needed. I was also well informed on the tricks to use it and clean it properly.
Okay, after that, did he ever get admitted again?
No, he only get nebulized once in December at our nearest klinik kesihatan.
Okay, does his asthma get worse at any particular time, like in at the night or in the day? And does his asthma affect his physical activities?
So far, no.
Okay, does he take any reliever? Okay,
No.
now I would like to ask about your family. Does he have any other siblings?
Yes, his older brother is 8 years old and his younger brother is 4 years old.
Okay. Is there anyone in your family that has asthma or any other illness?
Yes, his father and grandmother has asthma.
Does his father smoke?
Yes, unfortunately he does. He also has allergic rhinitis and on diet control for his diabetes.
How old is his father?
He is 34 years old.
What does he do?
He is a lorry driver.
Does he smoke inside the house or outside?
No, he smoke outside from the house away from the children.
Okay, thank you. And what about you? Do you have any known illness?
No.
Are there any household items in your house that can trap dust, like carpets, flowers, or even pets?
No, there's no carpet, flower or dust cat.
Do you clean the house often?
Yes, there were no cockroaches and no cockroaches using a broom and wash bed linen every week and dry them under sunlight.
Okay, thank you. So may I know where do you live?
I live in Batu Sebelas.
Is it easy to access to basic amenities in your area?
Yes.
How about your family financial? Do you have any struggle to provide essential for your family?
No, we can still afford to provide the best for our children.
Okay, thank you, ma'am, for your cooperation. Later, I would like to do physical examination on your son to know more details about his illness. Thank you. Okay, so now we move on to the summary of the case. Okay. So my patient, Abdul Arik, he is a 5 years old Malay boy, was admitted to HTIA with the complaint of runny nose for 4 days and cough for 2 days and rapid breathing for 1 day prior to the admission. So he experienced runny nose with clear discharge. There was also history of sick contact from school, where many have flu-like symptoms. His cough was productive with whitish glycerol about half tablespoon in content. Uh, okay. He had rapid breathing 1 day prior to admission, described as wheezing, and there was also intercostal and subcostal recession. He was alert and remained silent during the repeat breathing episode. He has only one meal a day, but no signs of dehydration seen. He then went to KK Klinik Kesihatan for nebulizer for 3 times, but his oxygen saturation remained 88%. So because of that, he was referred to HTAA for further management. So 6 months ago, he was diagnosed with asthma. 6 months ago, he was diagnosed with bronchial asthma and is on limited dose inhaler fluticasone 2 puff twice a day and limited dose inhaler salbutamol 2 puff when necessary. He has strong family history of atrophy. His mother had low hemoglobin but required no blood transfusion antenatally. He was delivered by spontaneous vaginal delivery and was jaundiced for a few days. His developmental milestone is appropriate to his age. He was breastfed until 6 months, exclusively breastfed, then mixed with formula milk up to 2 years and 4 months. He started his complementary feeding at 6 months and now take 3 meals a day. He completed all his vaccination. There were multiple episodes where he required nebulization at Klinik Kesihatan, but no admission before diagnosed with bronchial asthma. So from diagnosis until now, he only once went to nearest Klinik Kesihatan for nebulization in December. His father is a smoker, but he smokes away from his children. His father also has underlying asthma, allergic rhinitis, and is on diabetes diet control. His grandmother also has asthma, and he also often plays with his neighbor's cat. So he for physical investigation, uh, physical examination was done 2 days after Arif's admission. He was conscious, alert, and active. There was granula attached on the dorsum of his right hand with no active infusion. Everything else was normal, including his peripheral examination. His hydration status was also good. His vital sign was normal. His height, weight, and head circumference are also normal. And his respiratory, cardiovascular, abdominal, and neurological are all normal. Next, I will pass on to Suhaib for differential diagnosis.
Okay, hello. Can you open back the slide? Okay. Assalamualaikum warahmatullahi wabarakatuh. My name is Mohammad Suhaib. So I'll be presenting about the differential diagnosis and also the provisional diagnosis. So our provisional diagnosis is acute exacerbation of bronchial asthma secondary to pneumonia. So why do we suggest or why do we opt this for the provisional diagnosis? Because based on the history, the patient's mother did give a complaint with there is a high pitch sound during breathing, which is the wheezing. There's also an increase in there was tachypnea, and the patient itself has been diagnosed with bronchial asthma and have history of with previous similar presentation. There was also a multiple episode where the patient need to use a nebulizer to reduce the symptoms, and the patient was also given prescription and for the bronchial asthma. And finally, the patient also had family history of asthma, where the father and the grandmother has asthma. So for the differential diagnosis, for here I have suggested list out three differential diagnoses, which are allergic rhinitis, bronchiolitis, upper respiratory tract infection, and also the influenza, the flu. So for the allergic rhinitis, why is this actually one of the differential diagnoses? Because in allergic rhinitis, there is a complaint for the runny nose with the clear discharge. There was also cough, and also a family that has history of atopy, which is the grandmother and the father. But despite that, there is many points or many symptoms that did not arise in this patient that suggest it to be allergic rhinitis, which there was no history of allergy. There was no eye symptoms like conjunctivitis or rhinoconjunctivitis. There was also no eczema present on the patient's skin, and also there's no sign. The patient did not complain for any sinusitis. Next is bronchiolitis. For this, some of the symptoms that may suggest bronchiolitis are cough, wheezing, runny nose, tachypnea, and also respiratory distress. But also same with allergic rhinitis, there are other symptoms that the patient did not complain that rules out bronchiolitis, such as that the patient is actually 5 years old, where a bronchiolitis, the patient should be younger than 5 years old, below 5 years old. So there was no complaint of any fever, crepitation, or any cyanosis, as in the chief complaint or the complaint. The next one is the upper respiratory tract infection, URTI. In URTI, there is some of the complaint that the patient did say, which are the cough and the nasal discharge, but there was no any signs or symptoms of stridor, sore throat, fever, and also there was no complaint of any headaches, which rules out URTI as a provisional diagnosis. And finally, for the influenza, the common flu, the patient did complain with runny nose, and also the patient have a history with contact of a flu-like symptoms during when they went to schools. So the patient do have history of contacting a flu from someone else, and also there were a complaint of cough. But with that, there was also a lot of symptoms that did not arise in this patient that suggest it to be influenza, such as the fever. There was no sore throat, no complaint of any body ache, and also there is no fatigue. So as for that, our provisional diagnosis is acute exacerbation of bronchial asthma secondary to pneumonia. That is all for the provisional diagnosis and differential diagnosis.
Okay, so next, okay.
Continue.
Should I continue? Okay. So now I'll continue with the investigation and discussion on the investigation and management for acute exacerbation of bronchial asthma and also pneumonia. So next, for assessment of acute exacerbation of bronchial asthma, we need to assess three things for initial assessment. First is the symptoms. We need to look at the symptoms. If the patient have cough, wheezing, breathlessness, or fever, these symptoms are very important to know what are the causes of the AEBA. And then next is the triggers. What triggers the asthma attacks? So such as if there's any allergic to food or weather, exercise, or even infection. And the third one is the most important, which is the severity. So the severity will determine how we will manage the child accordingly to the categories, such as, for example, the patient are in mild, moderate, severe, or lung condition. So here are the parameters of the severity. We take a look at the breathless. If the patient get breathless when walking, when talking, or even at rest, they talks in sentence, phrases, or words, the alertness, the respiratory rate, the usage of accessory muscle, wheezing, the partial pressure of oxygen, pulse, and also the peak peak expiratory flow rate. Okay, so anyone want to try? Want to guess? What is the patient? Which category? Anyone want to try? What do you guys think? Okay, so if no, I think the patient is either in moderate or severe condition because for mild cases or mild asthma attack, they usually treat the patient usually treated at home, so they don't need hospital attendance. However, in moderate or severe or life-threatening condition, they need for hospital attendance and need prompt treatment. And this patient shows that he get breathless when he have the rapid breathing episode, because he can still respond. He remains silent, but then he can still respond to his mother. He is still alert. The respiratory rate increase. There is subcostal and intercostal muscle recession. There is also wheezing, but we don't know the partial pressure of oxygen, pulse, and the peak expiratory flow rate during the admission. But because of this patient need the attendance for attendance, the hospital attendance, so most likely the patient is in either moderate or severe condition. Is rarely helpful in assessment. However, patients such as pneumothorax, lobar collapse, or if the patient have pneumonia, and initial arterial blood gases on acute asthma. Okay, next. For the so on the right side of the screen, management of the AEBA. And the first one, diagnosis is done. Child with with oxygen saturation less than 92% need to be given oxygen by face mask. The second one is they should be given with beta 2 agonist, which is the bronchodilator, usually by using a nebulized salbutamol and addition of ipratropium bromide in severe cases. Third one is the oral prednisolone, which is the corticosteroid to reduce the inflammation. And lastly, intravenous magnesium sulfate or aminophylline or salbutamol if the patient fail to respond to inhaled therapies. Okay, next. So next is the investigation for pneumonia. So the first one is pulse oximetry. So pulse oximetry we done to check if the patient is in hypoxia condition or not. And chest radiography is indicated. Chest radiography is indicated when the clinical criteria suggesting pneumonia. And then is full blood count. Specifically, we want to look at the white blood cell count, where if there's increase in polymorphonuclear cells, which is the neutrophils, then it may suggest bacterial cause. And leukopenia, increase in lymphocyte, can suggest viral causes. Lastly, if ever blood culture is used for determine the specific etiology. However, it is the sensitivity is low, and positive blood culture only in 10% to 30% of patient. Okay, next. For the treatment of pneumonia, we give antibiotic. So antibiotic is given to treat the immunity and the causative agent, because majority of infection in pneumonia is caused by virus, so it does not require antibiotic. However, second line antibiotic should be considered if the patient there is no sign of recovery. And the second one is supportive treatment such as fluid, because patient with pneumonia present with respiratory distress, the oral intake usually withhold. So we need to give fluid to prevent severe dehydration. Next is oxygen. We should give oxygen to we need to give oxygen to reduce any mortality due to pneumonia. And cough medication and temperature control is to control the symptoms of pneumonia.
Cough medication, is it
It is
evidenced?
this is according to pediatric protocol. However, it is actually not recommended because it
Maybe
may
they mean, yes,
hmm?
because it continue.
it is not recommended because it can interfere with the error clearance. It say here.
Yes, that's why they may mean here by the cough medication is the mucolytic. Sometimes we can use the mucolytic, which dissolve the, but not the out of bench medication, which is not containing a lot of things which can be even harmful sometimes. Okay.
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 That's all from me.
Who else will present?
The next presentation is on the OSCE. Shall we continue?
Yes, please.
Okay. Wait ah. Oh my, something wrong with. Okay. Okay. Okay, can you see my screen? Yes, okay.
Yes.
So we shall proceed. Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So this session is prepared to test your understanding on the presentation, the long case presentation just now. So I'm hoping for participation from all of you, including other subgroups other than subgroup 2. Okay. So first question. A, given picture A and B. Question number 1. Name the following presentation. Who want to try? I need a volunteer. Aiman, can you try? Aiman Firdaus.
I want to try question 2.
Okay. Question number 1. Aiman Rahimi, are you there? Hello? Okay, who want to try? Okay, okay. Who
Let
are
me
you?
try.
Sorry, I cannot see your face. Okay,
Amni.
Amni. Yes? You may try.
Is it chest recession
Okay.
or
Almost.
respiratory, subcostal or intercostal recession?
Okay, what the answer is in your phrases just now. Okay. So what do you think? It is intercostal or subcostal?
Subcostal.
Okay.
Subcostal.
Okay, yes. Okay. How about B?
B is intercostal.
Are you sure?
Uh,
Are you sure?
yes.
Yes?
Yes.
Oh, I'm sorry. That is not the right answer.
So
You want to try?
and B is different lah.
Yes, A and B is different.
Oh,
Okay. B is given.
Oh, this one.
Yeah, what?
Hyogen.
Yes, you are correct. Okay. Okay. Question number 2. State 2 differential diagnosis of B. Aiman, you want to try, right?
B seems like ricket cell.
Ricket, pardon?
Ricket.
Okay. Other than ricket?
Asthma.
Asthma. Are you sure? You want to lock the answer?
I'm sure the ricket.
Okay, we'll see the answer. Kami got the answer correct. And yes, Aiman, you got the answer correct. Clap. Okay, no, I'm just kidding. Okay, Next question, question number 2. This question,
Come back. What is the clue for rickets here?
pardon, doctor?
What is the clue for rickets?
In children.
Yeah, in the picture. Come back to the picture.
Okay, wait, okay.
Why, Ayman, it is rickets?
Because I could see in the picture B, it seems like the shape of the body is like ricket. It's a feature of ricket.
What is these features?
Harrison sulcus.
Okay. Harrison sulcus can occur also with any chronic chest problem like asthma. What else?
Sure.
What's your Akmal?
Yes, doctor.
What's most important? It will guide you that it can be rickets.
Because the shape of the sulcus itself, because seems that ricket is characterized by low calcium, and when there is low calcium, the bone will be weak, right? And when the bone will be weak. When the bone is weak, so the presentation might appear as much as the I don't know what is that.
Yeah.
I don't know, doctor.
I need you. If you don't know, you can say I don't know. It is not even from Islamic point. It is not bad. You must go for the costochondral junction. Is there any beading or not? Okay, the costochondral junction. Is there any beading of the rickets? It will be appear in the periphery here. Okay, I think it looks like there is for the costochondral increasement. Of course, you must go and look. If you need to set rickets, you must put the wrist, especially the independent wrist, which is the left side. Is there any broadening of the wrist or not? Because it is one sign of rickets. Okay.
Okay, doctor.
Okay.
Shall we continue to the next question?
Yes.
Okay. Okay. Question number 2. We've provided the illustration. So question number 1, based on the illustration, state 5 etiologies of the problem. Who want to try? Atira, you want to try?
Allergen?
Okay, allergen.
Food.
Food. Okay, food can be also.
Food allergen. Infection. Infection.
Infection. Infection. Most probably, but there is infect. Okay, accepted. Other than that,
Dust.
dust. Okay.
Dust and smoke.
Smoke. Okay. Okay.
Okay.
Good. Okay. The answer is correct. Okay. Next question. Briefly explain the pathophysiology of the presentation of the disease.
I would like to try for this one.
Right.
Okay, firstly, the patient is exposed to either they either have a genetic predisposition, or they are exposed to the allergen or the trigger that can cause this asthma, or if there and that can lead to bronchial inflammation. So it can lead to the swelling, and also can lead to this will cause bronchial hyperresponsiveness. So the bronchial lining become more sensitive, and it will cause narrowing of the airway, and which can lead to the signs and symptoms such as the wheezing and the breathlessness and cough.
Okay, you are correct. Okay, I want to ask you two questions, extra question on this. What type of hypersensitivity is it?
Hypersensitivity type 1.
Okay. And what is the condition of the bronchus?
What do you mean with the condition?
What happened?
Elaborate. What happened to the, bronchoconstrict.
Okay, thank you. Okay, question number 3. What is the common presentation of the disease?
Can I try? Hello?
Hello.
Oh, okay. The common presentation, maybe patients usually come with wheezing, breathlessness, cough, and also lethargy.
Okay, you are correct. Thank you. Okay, so these are the question, the answer. Cold weather, genetic pollution, and pathophysiology. So I get it correct, and Alisa also get it correct. Okay, question number 3. List the parameters to assess the severity of asthma exacerbation into mild, moderate, severe, and life-threatening. Who want to try? We mentioned just now in the previous slide, in the case presentation slide by Atira. Anybody want to try? Or I call out your name? Ashraf, do you want to try?
Okay, I can try. Okay, the parameter is, the first one is the condition of the patient, breathless.
Okay.
The second one is how many sentences does the patient can talk during the attack. And the third one is the alertness of the patient. And we can also assess the respiratory rate, count the respiratory rate of the patient. And we also can see the usage of the accessory muscle. And then that, is there any presence of the wheeze? And we also can the oxygen level of the blood, and we can also count the pulse. And the last one is the flow, the PEFR.
Peak respiratory flow rate.
Flow
Okay.
rate.
So Ashraf, get them all correct. Thank you, Ashraf. Okay, next question. Question number 4. Ahmad Albab, a 5-year-old boy with underlying asthma, presented to AED with silent chest. What is the severity of the asthma? Can I ask for Maria?
It is life-threatening.
Sure?
Yes.
Okay. Yes, you get it correct. Okay, next question. State 2 other signs that probably present in this patient with regards to the severity. So I want Umaira. Do you want to try?
Okay, for the two other signs, wait, patient unable to speak.
Okay.
And comes with bradycardia. And also poor respiratory effort.
Okay, you get it. Oh, correct. Okay. Actually, there are more. We'll see afterwards. Okay. So, there will be rest training. So, Maria get it correct. And Umay also get it correct. Only that, they mentioned about paradoxical thoracoabdominal movement. Okay. We shall proceed to the last question. Question number 5. Saloma, a 9-year-old girl with underlying asthma, presented to AED after a history of high-grade fever for 3 days and productive cough with greenish sputum for 8 days. Upon auscultation, wheezing and bibasal crepitation was heard. The image provided is the chest X-ray of Saloma. Question. State 2 findings in. Okay, who want to try? 2 findings in the chest X-ray.
I want to try.
Okay, Aiman.
The left lung seems hyperinflated,
Okay.
and it seems that there is consolidation at lower lobar of the lung.
Okay. Yes.
May indicate pneumonia.
Oh wow. Okay, you try also for the diagnosis. Thank you so much. Okay, so Aiman get it all correct. There is patchy consolidation and hyperinflated lung. Okay, bonus question. Name the following device. Amni, can you answer this?
Inhaler.
Inhaler, okay. Second one,
Is it MDI?
MDI, are you sure?
Face mask.
Ah,
Oxygen face mask.
not really. It looks like oxygen face mask. It is not face mask.
What is that?
Nebulizer.
Yes, it is
Oh.
this is nebulizer. Okay,
Okay. Okay.
and this is MDI, metered dose inhaler, and this is nebulizer and compressor. Okay, so I think that's all.
Better to say it is blue
Blue.
in the eye because the color is very important. Usually blue or this color is used for the rescue in the eye, which is Ventolin or terbutaline. The other one, which is the steroid, it will be violet color. We are trying to make it different color so that the patient even not confused between the colors.
Okay. Thank you, doctor.
Welcome. Okay, so just a minute with Sufiana is the one, is the doctor now?
Yes.
Yes, Sufiana. So what is the diagnosis of your patient?
Acute exacerbation bronchial asthma secondary to pneumonia.
Can you add more points to the diagnosis?
Sorry, I can't hear you.
Can you add more points to the diagnosis? And you said, is it, what is the course of the asthma?
Cause of the asthma.
The course, is it intermittent or persistent asthma? If it is persistent, is it mild or moderate or severe?
I think it's moderate to severe asthma because he required admission to the hospital.
How many times?
Only once, but then he come for nebulization at the nearest clinic kesehatan.
Okay, so this is the most important point we need to know, that there's a big difference between the course of the asthma. To see is it intermittent, it means between the attacks the patient are completely free. You have very two important table inside your pediatric protocol, so you must go through it and put it in your mind. How to know is it persistent or not? We will speak about the coughing between day, coughing for night, the need for rescue, all this issue. But the attack itself, it is different. I mean, I may have intermittent asthma, but when it comes severe or life-threatening. So define if the attack of the asthma itself is mild or moderate or severe or life-threatening, it has another criteria. So you must go through this table. So at the end, you are able to tell us this is a patient with moderate resistant asthma, got ABI secondary to pneumonia with severe attack or moderate attack. This is the ideal. Okay? At least you must keep it in your background during discussion with the examiner or during discussion with yourself about the patient, how you are going to give him the care. Okay? So we need this, which is very important to two tables: severity of the attack and the course of the asthma. Okay, this is a very important point. So what is the treatment of asthma, Sofiana?
Sorry, doctor.
Management of asthma or treatment of asthma?
the management, we need to give oxygen by the face mask. Okay, and give the apa beta 2 bronchodilated such as nebulous salbutamol. And the treatment is include supportive treatment such as the fluid, oxygen, and also antibiotic.
But the asthma itself, what other treatment you need to give if the patient doesn't
In
didn't respond?
Inhaler.
Okay, no response. So must go for. Do we need to give any steroid or not?
If I'm not mistaken, the steroid inhaler is for to prevent the asthma attack.
Yes, oral or IV. Okay, according to the severity, you must know just the general lines that we are giving nebulization. If no response, maybe nebulization and the oral corticosteroid. Of no response, we are going for IV, okay, and the nebulization, and we can add also IV bronchodilators because the patient of asthma sometimes are so severe or life-threatening, he may need at the end even to be intubated. Okay, so what is the BEFR? BEFR.
Peak expiratory flow rate.
Yes. How can we diagnose the severity by the BEFR? So I need this one also to be added to the your OSCE, the severity of the attack, the course of the asthma. What is the BEFR? How can I measure it? How much is it? And how it can help me to diagnose asthma? And how can it help me to diagnose the severity of the attack? Is it mild or moderate or severe or life-threatening? Because it is very small machine spirometry in your hand, which can give you a lot of details. Okay, you need to add it to your presentation. Okay, so hopefully, how many candidates in your batch? Is it year 3? How many or students?
All year 3, there are 145 year 3 students, including other posting.
Oh, but our posting is how much? 40 or?
Our posting on 36 in the pediatric posting.
Sorry? How much?
36. 36
36.
students.
Okay. Okay. Good. Good. So you are welcoming and try just to help you to start strong, to continue strong. Okay. So we got a lot of details today about even the diagnosis of gastroenteritis. How can we diagnose it? Okay. And how can we concentrate the life-threatening condition inside it, especially the dehydration. Then we got also for the asthma, and we know how to define the asthma and differentiate it from different diagnosis. At the same time, how we can diagnose the severity of the course of the asthma. Is it intermittent or mild or moderate or severe resistant? And how can we diagnose the severity of the attack itself? Is it mild or moderate or severe or even life-threatening? Today we are dealing with two of the most important common problem in pediatrics. I hope you start, inshallah, I started already in the good pathway. I'm happy with you, inshallah, for your good start. Okay, I will give you are, I will give marks. It is considered for the team, but under Balkis, Ali will give her 7, and Nurin Sufaina will give her 7.5. Okay. Please, you need to make correction of the slides which I give you in your presentation, and you need to send me that slides. Okay. Do you need to ask any questions?
Doctor, can I
Yes.
ask?
Yes.
Can we treat pneumonia with bronchodilator also?
Yeah, this is a very important question because many of the cases of pneumonia, it will came with rhonchi. Do you know that wheezes means that the voice which we can hear by our ear? If we hear it by stethoscope, it is rhonchi. If they find the patient with severe rhonchi, especially if there is a history of allergy in the family or like that, primary, it is a fluid which you need to be adjusted, okay? But sometimes you may need, it is not a fixed treatment, but sometimes we will say to try just to give him the nebulization and wait to see how is the RR. It is improving, we can consider it. If no improve with the bronchodilator, the RR is still high like that, it may need, he will not get benefit of that unless the patient his background is asthmatic. Of course we need.
Thank you, doctor.
You are welcome. Any other point?
Doctor, I have question. For next week, we have procedure presentation which you at 2 p.m. So how we will conduct the procedure presentation?
Procedure presentation. Yes, you need to divide how many candidate, which group is it?
Subgroup 2. This group.
Is it my mentee?
Yes.
Oh, I think I am not in a group with you. You can make a group and add me. Okay. Because I will divide the procedures between you. Okay, everyone will present from the simple to the complicated procedure, from simple like blood taking, like blood culture, CBD, then we are going to lumbar puncture, a lot of issue. I will give you the titles, and also I hope I can send you an example from your previous student, just to try to get benefit of that. Okay, but you will do, like every one of you will do simple presentation for that, and he must be able to give at the end a clinical hints. The most important for doing this procedure is blah 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 blah. Okay, just make a group and add me, and inshallah I will reply for you. When is it? Which day?
We have 2 days for next week. The first one on Monday, and the second one on Thursday.
I see. I see. Let us see. We can arrange it for you. No issue. Just add me to the group, and I will give you feedback. Okay, by another presentation before, and how to divide it between you.
Thank you, Prof.
Assalamu alaikum.
Thank you, doctor.
Okay.
Thank you, doctor.
Thank you, doctor.
Thank you, doctor.
Thank you, doctor.
Just to go for your praying time. See you inshallah again. Assalamu alaikum wa rahmatullah.
Waalaikumsalam.